our colleagues. My name is Rwahita Satyawati. I'm physiatrist. I work on Surabaya, on Dr. Sutomo General Hospital, and my department is rehabilitation medicine. I want to share this morning my experience to found a proper brace for our patient with scoliosis. Let's see this movie, a short movie. And we can see here that's a girl that moves freely without any significant limitation in moving. Okay, I will talk you about my clinic. I start my clinic with growth tolerant clinic. A problem with growth is so important for our teenagers. And we can see I start in 205 until 213. That is 4 to 9 clients. But when I start in 208, until now, my client in scoliosis is already 700 more. So we can see here that scoliosis is more important. Scoliosis is a disease, but growing problem is just maybe cosmetics for us. And we can see here also that is 127 clients, it's combination. It means they come because of growing problem, but because I see that is a scoliosis also, I give them scoliosis program. And from 2002 scoliosis problem, there is a half that the COP is more than 20. We can see here that's an indication for brace and there is indication for surgery. It's your part. And unfortunately, just 87 already use the brace, but another is refused for several reasons. That's the same. That is the reason why client refuse to use the brace. Almost all of them refuse because of the same and discomfort problem. So that is a big problem. If we ask the patient to use the brace and they refuse, me as a physiatrist must think what kind of brace that we can give to the patient that solve that problem because they refuse to use it. So we can see here that is a static brace that usually I give to the patient, and it needs almost 2 weeks to have fabrication. That is the complication of the process. We can see, I think you already know about that. And now, I found another possibilities, another kind of brace that help my patient, that help my client. That is a kind of dynamic brace that only need 2 hours to have fabrication. So the patient can came to our clinic and in 2 hours they already have the brace and they can go home happily. That is the process. Can you open the presentation? Yeah. You found the, can I borrow yours. Yeah. That's how we measure the brace, the TriaC. Just put that measurement in the axillary line here. So you can make what kind of brace that your patient needs, small, medium, or large. That's how to measure it. And the orientation is the thoracal curve. If your patient curve in the thoracal part is the right side, that's need the TriaC in the right curve. So you can measure it. Very, very simple. That's the process. So simple because it's a knockdown. You can see in our stand here there. That's the process. Just need 2 hours. Why the name is TriaC? That's because of give a 3C benefits. The first C is comfort, the second C is control, and the third C is cosmetics. And I very happy with this one brace because although it is the dynamic and also the new brace, but I can see clearly where is the 3-point pressure working. I think I agree with you that the 3-point pressure is the most important part if we give a brace. That is a sample of my client. That's we taught the brace, and shortly after we gave brace, we mix a new X-ray. Then we can see the result. That's a decreasing 2 degrees here in thoracal part, and also 10 degrees in the lumbar part. We can see also here another example of client decreasing in 4 degrees in the thoracal and 8 degrees in the lumbar part. That is the same girl. We can see that the girl used brace when he danced saman. Okay, it's how to use TriaC is simple one. So comparing with another dynamic brace that's so complicated to use it, it will give a good compliance for our client. Okay, so I already done my introduce. And I will ask Matthias to give another presentation. Matthias, may you introduce yourself, please?
Thank you, Dr. Ruthie. So, yes, I'm happy that I'm here on your annual meeting. My name is Matthias Roller. I'm from Germany, and I'm working on the University Hospital of Groningen. My profession, I'm a certified prosthesist and orthosist and a Master of Science in Neuro-Orthopedic Disability Management. And I have now more than 13 years experience of the dynamic bracing, and I want to share with you my experience. So, yes. When it comes to the conservative treatment, you have 2 options. In bracing, you can use a static brace or a dynamic brace. I think both braces are important. I want to share today my experience with the dynamic brace. Yes, how I told you, we started over 14 years in the University Hospital in Groningen with this dynamic brace. And you see here the first prototypes. And yes, we worked on it, and this was a TriaC 1, and now we have the TriaC 2. Yes, Dr. Ruthie already talked about the importance of the 3 Cs. I think it's not only in the scoliosis brace, it's also in all bracing. If you work together with your certified prosthetist and orthosist, always take care of the 3 C's, that the patients are really wearing the brace. Yes, what was the idea behind the dynamic brace? We saw often that the kids refusing the brace, and even if you see they have a scoliosis over 20 degrees, but then they say, let's wait a little bit and wait, and then the important time where the curve is good, manageable, we lost. And then we start maybe with the early 40-degree cupped ankles, and it's much more difficult to manage a curve in the 40s than in the around 25 to 30. So we really want to give them a possibility to early treatment, a permanent control, and it was also when we started with the dynamic brace that we want to have a natural movement. And I think Dr. Roller showed a video of the dancer. It was really impressive for me. By the way, it's a nice dance. Yes, I think it comes to the indication and contraindication. Both are very important. So the indication for dynamic brace, there are between 15. We start normally in Germany with 20-degree bracing. Sometimes if the family background is already, you see the mother, the grandmother has already scoliosis, and you see 15-degree, you can start earlier. Yes, I have a few experience with cerebral paralysis patients who are able to walk. That's important. And another big group are the painful adolescent scoliosis. We use it. You should not use it if your patient has the apex higher than DH7 or below L4. Because it is a dynamic brace, it doesn't work at all if your patient has a paralytic scoliosis. And we are limited about of the forearms if the patient is under 120 centimeters. Yes, now it comes to the strength and the weakness of the dynamic scoliosis. Everything have 2 sides, so it's perfect for long curves to treat. If you have small, hard curves, especially in the thoracic part, it's more difficult. It's easier in the lumbar part, so the correction is a little bit better in the lumbar part than in the thoracic part. Yes, and we have no influence really on the sagittal view. I think the sagittal view is very important. So in the past we make a lot of stomach pressure and we try to bring the spine in a straight position to it's easier for us to control it. But on the other hand, we make it unstable, and we want to have a nice sagittal profile. So we let the patient in the normal sagittal profile. But if you have a patient with a kyphoscoliosis, you cannot use this brace. So you have no influence on the kyphosis. Yes, I think important is that the patient is able to do the activity of daily living. And I think the second point of all these points I want to bring out, invisible under the clothing. And you know, if the patient is now 12, 13, 14 years, mostly girls, they want to be normal. They want to don't different to the friends in school. So this is what I think very, very important. Yes, Dr. Ruris already showed us that we have principles, and we have to bring these principles as in the static brace to the dynamic brace. And yes, here you see the clear 3-point. And you have also 1 point here if you have a thoracic curve that and the shoulder is on one side lower, so you bring the shoulder up. Yes, you have It's not directly out of the box, so you have to modify it directly to the patient, and each patient is a little bit different. Even if we have small, medium, large, you need adjustments from the certified orthotist to do. I just want to show you a few samples out of my daily practice. So if you have a very low curve, so you have to do adjustments on the palate. If you have like a C form here, so also you have to change the pressure points in the brace. So this is a boy, he is 13 years old or 14 years, and he has a C form, and you can see clearly here the it's not congruent, and we changed it a little bit, the palate here, to do it a little bit higher pressure, and you see here the result in the X-ray. Yeah, the patient compliance is always a big question, and Juni et al. Shows us that only 20% of our patients are wearing the brace how they should. So it's a big problem. I think it's Germany, it's a cold, long winter, so it's easier to wear a brace, but here in the nice Indonesian weather, Bali, I think it's much more problems to wear a clothes. I do in the moment the research in the University of Groningen, so we use small sensors and they counting exactly the time of the wearing, and it's very interesting what you see on the results sometimes, what the patients, how long the patient's wearing the brace. But we are midst in the research here. Yes, I just want to now come to the end, and I want to present you a study. So the clinical effects of the continuous correction force in the non-operative treatment of idiopathic scoliosis, a prospective cohort study of the TriaC brace we did. And the question was, is it possible to effectively stop the progression of risk patient group with the TriaC? So the TriaC is now only 14 years old. The Boston we have many years, so we have to really show if it works or not. So from 212 patients we treated on the University Medical Center in Groningen, only 63 patients, 30%, selected the criteria. The criteria was the cup angle from between 25 and 30 degrees. The cup angles under 30 degrees, they have to show us a progression of more than 5 degrees before we start. With a stage 0 or 1 was important for us. Girls premarital or less than 1 year postmarital. This group exactly showed Lowenstein and Carlson that those groups have a progression risk of more than 70%. So we want to show on a higher risk group. 63 patients, the primary curve was 30 degree cup, secondary curve 22, there is a 0 to 1, and average age of starting the treatment was around 11, and the average age of the end of the treatment was nearly 16 years. 7 patients, including the study, had a single curve, and 56 patients has a double curve. 6 boys and 75 girls, like it's normal in the daily life. We have more girls. Yes, the outcome of the study I show here. Lowenstein and Winder did the study with Boston Brace and Milwaukee. Landauer, it's from Austria, and Wimmer. They used Chenot brace, what is very popular as a static brace in Europe. And Bulthaus et al. Used the dynamic brace, the TriaC. And you see in the starting phase, it was an initial correction. The Chenot brace did the most correction, but on the end, after finishing brace, all brace types came to the same result if, and it's very important, the compliance was okay. The compliance is important. Landauer and Wimmer did a study and showed the same correction with the non-compliant group was fast away from the good compliance group. Yes, so in the end we had a result of 76% patients with success and 24% patient, it means 15 patients with non-success. What is, if you look at the international literature, average failure rate? I say thank you, Terry Kashi, and I'm happy to be here. Thank you very much.
I invite all of you to